Hi everyone, welcome to our module on congenital and developmental abnormalities of the respiratory system. So these are extremely important because they are usually present immediately after birth, often presenting as severe respiratory distress. Most of these conditions are not usually random, they are the direct result of errors during the embryonic development. So if you understand the embryology from the previous video, this becomes very logical and easy to understand. Before beginning with the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everyone. If you find it useful and wish to support its development, you can do so with the link that's on the screen and that's also pinned in the description. You can contribute to us with any of these payment methods. Congenital lung disorders are typically present in the neonatal period. The baby is born, and within minutes to hours, the baby starts uh, with difficulty breathing. The key thing to understand is that these problems usually start before birth and not after birth. Most of these conditions are due to abnormal lung development or external factors that restrict lung growth. Also, many of these conditions are not isolated. They are often associated with other systemic abnormalities or as part of other syndromes. So, whenever you see a neonatal respiratory case, we always need to think, is this a part of a larger development problem or is it an isolated condition? Now, let's start with pulmonary hypoplasia. This simply means that the lungs are underdeveloped. The bronchial tree is smaller and fewer airways are formed, and the lung cannot perform proper gas exchange. Now, the most important cause that we need to remember is the oligohydramnios, which means decreased amniotic fluid. Now, why does it matter? Because the fetus needs amniotic fluid to expand the lungs during the developmental stages. So, if there's less fluid, the lungs don't expand properly, and so their growth is restricted. As a result of this, there is a small, poorly functioning lung, which leads to respiratory failure after birth. Now let's move on to one of the most important concepts, that's the Potter sequence. So this is not just a syndrome, it's called as a sequence because one primary problem leads to a chain of events. So the starting problem in this Potter sequence is bilateral renal agenesis, meaning that both the kidneys fail to develop. Now we need to remember that fetal urine is a major component of the amniotic fluid. So if the kidneys are absent, urine is not produced, leading to severe oligohydramnios. And because of this low fluid, the fetus gets compressed inside the uterus. So the entire condition is like a cascade. So renal agenesis leads to oligohydramnios, and this eventually leads to fetal compression and lung underdevelopment. Now let's look at how this appears clinically. This there's a classic triad that we need to remember. So first is the flattened facial features. This happens because of continuous external compression. Secondly, it's the limb deformities. Again, this is due to restricted movement and pressure. Thirdly, there's the pulmonary hypoplasia, which is the most important condition because this leads to death. So the baby is usually born with severe respiratory failure due to underdeveloped lungs. So this Potter sequence is a classic exam vignette. So a newborn with characteristic facial features, limb abnormalities, and uh, respiratory distress. So we need to think of possibility of Potter sequence immediately. Now, imagine a newborn with severe respiratory distress immediately after birth. So, on examination, you notice something unusual like the vowel sounds in the chest region. So, this is the classic presentation of congenital diaphragmatic hernia. So, in this condition, there's a defect in the diaphragm, which allows abdominal organs like the stomach and the intestines to move into the thoracic cavity. Now think about what this does during development. So the lungs are trying to grow, but they are being physically compressed by these abdominal organs. So problem is not just the hernia itself. The real issue is with the poor lung development before birth. The most common type of congenital diaphragmatic hernia is called as a Bochdalek hernia. So this occurs due to failure of closure of the pleuroperitoneal canal during development. So this usually happens on the left side. So now the most important thing is why that's the left side that's commonly affected. So because the liver on the right side provides some protection while the left side is more vulnerable. So this leads to Bochdalek hernia more commonly on the left side. So if you see a question mentioning a left-sided diaphragmatic hernia in a newborn, so this is almost always Bogdalek hernia. So now let's understand what happens step by step with regards to the congenital diaphragmatic hernia. During fetal development, the abdominal organs move into the thoracic cavity through the diaphragmatic defect. As a result, the developing lung on that side gets compressed. There's compression of lung. This prevents normal growth of the lung, leading to pulmonary hypoplasia. So by the time the baby is born, the lung is already underdeveloped. So that's why even after birth, oxygenation is severely compromised. So we need to remember that the damage is already done before birth in cases of congenital diaphragmatic hernia. So now let's translate this into a clinical sequence. So the baby presents with severe respiratory distress and the abdomen appears scaphoid, meaning that there's a sunken abdomen. Why does this happen? Because the abdominal contents are not in the abdomen and they move into the chest. So this leads to a sunken abdomen. And when you listen to the chest, instead of breath sounds, we may hear vowel sounds. So this combination of respiratory distress, scaphoid abdomen, and vowel sounds in the chest. So this is extremely characteristic of diaphragmatic hernia and this is one of the most classic presentations. So now let's try to understand why this condition is so dangerous. You know, because the lung has not developed properly. So that's the main reason why this congenital diaphragmatic hernia is extremely dangerous. So even if you try to support the baby after birth, the lung simply doesn't have enough functional capacity. So that is the reason why early diagnosis, often sometimes even before birth, is extremely important because poor oxygenation or underdevelopment of lung can be a life-threatening situation for the baby immediately after birth. And we also need to remember that this is not a problem that starts after birth. It's a developmental issue that has been present throughout the fetal life when the baby is inside the uterus. Now let's start with bronchogenic cysts. So these arise due to abnormal budding from the foregut during the developmental stages. Normally, the foregut gives rise to the respiratory tract, but if this building process is abnormal, a cystic structure can form. These cysts are typically fluid-filled and are well defined. So structurally, they are the developmental remnants of the airway system that did not form correctly. So these bronchogenic cysts are those developmental remnants of the airway system, to be precise. And this is because they do not form correctly. Clinically, most bronchogenic cysts are asymptomatic. They are often discovered incidentally during imaging done for some other reason. So, however, problems can arise if the cyst becomes large enough to compress the nearby airways, or if it gets infected. This can lead to severe problems. In such cases, the patient may present with recurrent respiratory infections or airway obstruction symptoms, airway compression symptoms. So while many are actually silent, they can become clinically significant depending on the size and complications. Now let's move on to one of the most important congenital anomalies, the tracheoesophageal fistula. So this occurs when the trachea and the esophagus fail to separate properly during development. So normally a septum divides the foregut into two distinct tubes, the airway and the food passages. The airway is the trachea and the food passage is the esophagus. So whenever this separation fails, an abnormal communication forms between this trachea and esophagus, so fluids and food can enter the airway, which can lead to serious problems after birth. The most common type of tracheoesophageal fistula involves two components. The upper part of the esophagus ends blindly. This is called as the esophageal atresia, and the lower part is abnormally connected to the trachea. The upper part ends blindly, leading to esophageal atresia, and there's a distal part. The lower part is abnormally connected to the trachea, so this could lead to distal tracheoesophageal fistula. So when the baby tries to swallow, the food has nowhere to go. It accumulates and may spill into the airway through the fistula. So this specific pattern is extremely important and is frequently tested. So the upper esophagus ends blindly and the lower segment connects to the trachea. Esophageal atresia with distal tracheoesophageal fistula is the most common variant of tracheoesophageal fistula. Now let's translate this into uh, actual clinical pictures. So whenever there's a newborn who is fed and they immediately to start with choking during feeding, coughing and cyanosis. So there is excessive drooling because the swallowed material cannot pass into the stomach. And cyanosis occurs because milk is entering the airway, which leads to respiratory tract obstruction. So the key pattern is that feeding leads to choking and this leads to cyanosis. This is one of the most classic neonatal presentations you'll see in all the kinds of exams. Whenever you see feeding related respiratory distress, we always need to think of a possibility of tracheoesophageal fistula. Now let's look at choanal atresia. So this is a congenital condition where the posterior opening of the nasal cavity is blocked. Normally, air flows from the nose into the pharynx, but here this pathway between the nose and the pharynx is obstructed, and this obstruction can be on either one side or on the both sides. If it is unilateral, the symptoms might possibly be a little bit mild, but if it's bilateral, this becomes a serious life-threatening emergency immediately after birth. To understand why this is dangerous, you need to remember and try to understand one key concept is that newborns are obligate nasal breathers. This means that they primarily breathe through their nose, but not their mouth. So if both the nasal passages are blocked, the baby cannot breathe properly, and this leads to severe respiratory distress. So that's the reason why bilateral choanal atresia is a neonatal emergency. Now, here's the most important exam pattern. The baby becomes cyanotic during feeding but improves when crying. So, now let's try to understand why this happens. So, during feeding, what actually happens is that the mouth is occupied and it's closed, and since the nose is also blocked, the baby cannot breathe. So, oxygen level drops, and this leads to uh, no airflow, and this leads to fall in the oxygen levels. But when the baby cries, the mouth opens, allowing the air to enter through the mouth into the pharynx, and then cyanosis improves. So this alternating pattern, worsening during feeding and improving with crying, is extremely characteristic feature for choanal atresia. Choanal atresia is often not an isolated finding. It is commonly associated with a condition that's called as the charge syndrome. So each letter in this charge syndrome stands for a feature. C stands for coloboma, H stands for heart defects, A stands for atresia of Koena, R stands for retarded growth, G stands for genitourinary anomalies, and E stands for ear defects or ear abnormalities. So if you see coronal atresia, we always need to think, could this be a part of a larger syndrome like charge syndrome? So this charge syndrome is frequently tested in all the exams. So charge can be used to memorize this syndromes, and the mnemonic stands like C stands for coloboma, H stands for heart defects, A stands for atresia of Koena, R stands for retarded growth, G stands for genitourinary anomalies, and E stands for ear abnormalities. Now let's quickly try to summarize everything that we've learned in this module. So pulmonary hypoplasia usually occurs when the lung development is restricted, often most commonly due to low amniotic fluid or oligohydramnios. Whereas Potter sequence starts with renal agenesis, and this leads to oligohydramnios and underdevelopment of the lung. Congenital diaphragmatic hernia causes the abdominal organs to enter the chest and compress the lungs, and tracheoesophageal fistula presents with choking and cyanosis during feeding. And most importantly, choanal atresia presents with cyanosis that improves when the baby starts crying. So the key to solving all these questions is the pattern recognition. So if you understand the underlying mechanism, the diagnosing the condition becomes pretty easy. I hope this video helped you. I'll be right back with the third video of our pulmonology series. Till then, bye.